Great. I'm going to
Yes.
take that as a yes. And if I flip over to my screen, can someone say out loud whether you see my TriNetX overview screen?
Yes.
Yes.
Yeah.
Terrific. Thank you. I'm more used to using Zoom than Teams. So thank you for having me here today. Hope that this is useful, and reach out in between the two sessions to let me know what could be more useful. I'm going to do three things today. About 10, 15 minutes of an overview of what TriNetX is. 5 minutes looking at a couple of papers that have been published in the past couple of years using TriNetX as a platform for retrospective cohort research. And then doing a live demo with you all to replicate a recent paper that used TriNetX to look at cardiac rehabilitation. I already incorporated screenshots from a practice session I did of that demo. So if things go awry technologically, or if people want to look at this asynchronously, those are already in there. So the objective for today is that by the end of this session, these are the objectives specifically for today. There'll be other nuances next week. Today is just being able to describe TriNetX, appreciating the value of TriNetX as a platform for conducting publishable research, and beginning to use TriNetX. So TriNetX is a federated clinical data research network. Federated means we retain control of the data. There's dozens of health systems that pump their EMR data into a place where TriNetX can access it fully de-identified. Multiple years of data from each health system, for example, since 2010 from VCU Health System. The VCU data is from Epic, but also legacy systems, Cerner, other things that predated Epic, but also the cancer registry. TriNetX includes sophisticated query tools, and those use controlled medical vocabulary such as ICD-10 codes, CPTs, LOINC codes for labs, etc. And it also has, as Amol was just alluding to, it has built-in analytic tools, so you don't have to know how to run raw data through something like Stata or SAS. You can use the built-in analytic tools to do pretty sophisticated statistical analyses that are suitable for publication. There's no PROC step or IRB required for getting an account or initiating studies or doing work within TriNetX platform. There's no funding required. So that's why we think, as Amal was saying, it's kind of a low threshold or low hurdle place to start doing hands-on research if you haven't already been doing that elsewhere. TriNetX is one way of getting at real-world data that can drive real-world evidence for a variety of purposes. Within TriNetX, there's actually multiple networks of health systems data. So there's a VCU-only network that we can get to that people outside of VCU cannot see VCU only. Their data in there include Community Memorial Hospital, so downtown, as well as there, all the ambulatory sites, at least to the extent that the clinical phenomena are recorded in Cerner or Epic, right? So if clinical phenomena are recorded in an EMR used at the VA or at Sheltering Arms Institute or Sheltering Arms ambulatory sites, those I believe will not be in the TriNetX because they're not in the VCU EMR, if that makes sense. From both the VCU TriNetX network and the research TriNetX network, not only can you do the onboard analytics, but you could also download data, again de-identified, for other manipulations and other statistical analyses. And there's other networks as well in here that you can access and you can explore how things look differently between, for example, VCU only, the relatively new Virginia Collaborative Network, and the US Collaborative Network. If you need troubleshooting, if you need help with your account, if you want to look at some other resources that the Right Center has for, they're the ones who host TriNetX. You'd go to the Right Center website and you get these kinds of pieces of information about how often TriNetX data are updated from VCU and the other components of VCU data that are in there. I do want to point out some limitations that while other health systems make clinical note and report based data available in TriNetX for natural language processing, VCU does not. And while some other health systems put their genomic, mutation kinds of things, data out there from their EMRs, VCU does not. One thing that you might be asking yourself is, well, if I do want to get those things, how can I get them? Is there other ways I can get VCU health system clinical data or billing data for research other than through TriNetX? And yes, you can. If you're doing any kind of clinical trial feasibility, TriNetX is pretty much the way to go unless you have very, very complicated inclusion exclusion criteria for a clinical trial. The way to find other data, whether something else is possible, would be to explore that with a consultation from either the Massey data analytics folks or the Right Center analytics folks, either of whom can be reached by putting in a ticket at informatics.vcu.edu. There's a number of other data sets available for research that we can access from VCU, the Virginia All-Payer Claims data set, Vizient data, Cosmos, which is the back-end research database for all EPIC instances, the National Cancer Database, Amol CMS data, data from the Mid-Atlantic Twin Registry and other twin registries at VCU. So how can you use TriNetX? A lot of people have been using it for quite some time on clinical trial feasibility and cohort discovery. This is great for grant applications where you need to demonstrate that you have adequate sample size to do a proposed project, or if you're considering an investigator initiated or industry sponsored trial, do we really have enough patients arriving in a month that would meet criteria to make it sensible to open that trial, or would it not be fruitful? Using the onboard analytics, there's a wide variety of research study designs and approaches and goals that you can address. A couple of things that will you find pretty easily on PubMed that have been published in TriNetX are outcomes research and epidemiological research. Certainly a lot around healthcare delivery science or implementation science. And it's also a great way to explore equity issues, excuse me, or disparities. And I think this is still relatively underused. And as here today, we're also trying to leverage TriNetX as a way to help people to learn how to do research, even if they don't have access to a funded mentor or a lab or other kinds of research opportunities. That TriNetX levels the playing field so that anyone can explore research questions. And we're trying to we're offer more and more engagement of TriNetX within health science curricula, such as in the School of Medicine curriculum. Here's some recent papers published by VCU faculty, residents, and students. These two on hematology phenomena were published by an oncology hematology fellow in within the first 2 years of his 3-year fellowship. So take a look at some of these, but also find some inspiration if you're a trainee to look at TriNetX as a way to get a publication, to explore research without having funding or a master's degree in biostatistics. You all should have access if you have problems. Again, you can reach out to the Right Center, and this is the URL for actually getting into TriNetX. Uh, Students and trainees and staff who are not faculty have to have a faculty sponsor. Once you're in TriNetX, in addition to these kinds of seminars and workshops that we do here at VCU, If you click on the question mark within TriNetX, it'll take you to all kinds of resources, including live and recorded trainings. They have about 5 live trainings a month, and then 12, 13, 14 recorded ones as well. A number of medical students that I've worked with use browsers other than Chrome. I don't have any technical issues using Chrome for TriNetX. Other people, I don't know what they're using exactly, but they will, TriNetX will close after about 10 minutes and they have to get back in. So if you're having that kind of a technical problem, that's not by design. You shouldn't be satisfied with that. Explore using a different browser. Um, any questions so far?
Dr. Cassel,
Yes.
do you know, this is Rajshekar, I'm from the Sparkwood side. Do you know for the queries that are run for non-VCU institutions that are de-identified, if those de-identified records are requested, do you know if that has to go through any sort of I know to run the queries you don't need the IRB, but to access that de-identified data, do you need any sort of IRB
Yes.
approval? Okay.
Yes, either PROC or IRB. There's been changes over the past couple of years about what, do I go through PROC? Do I go through IRB? But one way or the other, you need a non-human subjects research determination letter that acknowledges that this is not human subjects research because it's de-identified data. You can also get full IRB review for re-identifying VCU data only if you needed to reach out to patients as part of a project, IRB approved project to survey them or to bring them in for another intervention or something like that.
Okay. And that would apply also to data not from VSTU potentially.
You, we cannot re-identify anyone not from VCU. Sorry for the double negative, but you can only re-identify patients using the VCU network of VCU only patients.
Gotcha.
So if
But
you
for anyone
request
who, I'm sorry, go ahead.
if you request de-identified data, you also will not see in that, from a network other than just VCU, you won't be able to distinguish VCU patients from non-VCU patients. So it's one of the things that is de-identified is the institution or the site.
Perfect. Thank you. Yep. That's what I wanted to know. I appreciate that.
Sure. Thanks for your question. All right. I'm gonna move on and then we'll take some more questions and clarifications. There's two main components of TriNetX. We'll be looking at the query builder today and build a simple query. The menu is always on the left. Sometimes the words are minimized, but you'll still see the icons. This is where you build your inclusion and exclusion criteria. And then when you count patients, that saves a cohort of patients over here on the right, and you can have a history and a whole set of all kinds of different queries within a larger study. So this was a study that I had created looking at SGLT2 inhibitors and magnesium levels. I can have lots of different queries within that. I can create as many different cohorts as I want within that. Each query that I write creates a cohort, and each cohort can be modified by going back into the query. The onboard analytics are the other major component of TriNetX. These are the 6 that have been available to us for some time. Analyzing outcomes for a single cohort is what we'll look at in the recent paper on heart failure. Comparing outcomes for 2 groups, for 2 cohorts, we'll look at a quick example of that just on a couple of slides. You can see some of the other things here as well. And then 4 new analytic types that have been made available to us, I guess kind of in beta testing, include logistic regression, which we've been looking for some time. In fact, you could see other institutions have had access to that before, and you'll see in some papers, even though they didn't download the data, you can see that they've applied the logistic regression within TriNetX to their analyses. Here's a little bit more information on built-in analytics versus downloading the data set. If you're a trainee, a student, I highly, strongly recommend, vehemently recommend you pose research questions that do not require download. Um, if your research question includes things like composite variables or indices or requires other kinds of multivariate analyses or a different kind of cohort balancing other than one-to-one propensity score matching, I would put that aside and stick to things you can do within the platform, because when you download data from TriNetX, you are getting some of the largest data files that I've ever seen people try to work with. So you need to have significant space and savvy for both the data management step and also the analyses that you're going to want to do. Working with people to try to help them understand, well, what can I do and what can't I do in TriNetX at all? But then also, what can I do with the built-in tools versus what would I need for downloading data is something I'm happy to help people with. That's, as Amol said, through this medical education faculty fellowship that I have in the School of Medicine this year. That's part of my job, is not just to show people TriNetX, but to help people to understand which questions or flavors of questions are appropriate for TriNetX. So the palliative medicine fellows last year were posing some questions about opioid prescriptions for adult cancer patients, and they posed a number of descriptive questions and then also some quality of care and safety related questions that could be answered within the platform. And we started to work through some of those. They only have a 1 year fellowship. Um, there were other questions that they were interested in, including computing morphine equivalent daily doses when people are getting both short acting and long acting opioids. It's certainly possible to do that with granular downloaded data, but that isn't something that you could program using the query builder or the outcomes. So there's a number of things like that that could only be done with downloading the data, which is certainly beyond their time and resources for their 1 year fellowship. And they also were interested in things like insurance status and structural and social risks for health. Those, I would say, are not. Insurance status is definitely not available in TriNetX, and although there are Z codes for social and structural risks, they are so infrequently used in EMRs that I would say TriNetX is not the appropriate place to explore those kinds of research questions. I mentioned within the analytics, if you're comparing to cohorts on outcomes, it does cohort balancing. And that's one of the great things it can do to provide kind of citizen data science, if you will, that you don't have to be a statistician to do propensity score matching. It'll walk you through each of the steps that you need to do to, after you've already lassoed your cohorts to balance them. So when it goes through the process, you can also look at the metrics it provides to see how well cohorts are balanced on your inputs, on the propensity covariates, if you will. And you can see how it performed, where for the cohort 2 in one of the oncology fellows studies, it didn't need to remove or fail to match many of the exemestane patients, and it reduced the much larger anastrozole cohort to the same number for one-to-one matching. That was very good. And then the fellow went in and did 3 sets of pairwise comparisons for adverse events after receiving these aromatase inhibitors. So this is the kind of output that you can get in TriNetX for looking at risk difference, risk ratios. Um, you know, pretty easy to run this and pretty easy to interpret it. Going to show you quickly the study that was done by Ben Van Tassel and colleagues here at VCU from the School of Pharmacy and from cardiology, where they posed a question about the risk of new onset heart failure during the first year after an acute anterior wall ST elevated myocardial infarction. can see there's a single cohort study with different operational definitions of their outcome variable, and they did a time to event analysis to see when that occurred according to different operational definitions or ways of measuring heart failure. Couple of studies that were published by the hepatology group early on in the COVID pandemic did require data download. So the Van Tassel study did not require downloaded data. They did the analyses just within the platform. And in fact, if Ben was doing this talk, he would tell you that once they had laid out their logic on a piece of paper and their inclusion and exclusion criteria, what would go into the different operational definitions for their outcome variable, they did the TriNetX work, he says, in one afternoon. Right? They already knew how to use TriNetX. It wasn't their first TriNetX rodeo. But just using the onboard analytics, you can get results very quickly. The studies by Richard Sterling and colleagues used the downloaded data because they had a number of things they needed to do to compute the FIB4 score, which is a multivariable index and is also, I believe, weighted or has multiplicative factors that required them to download the data to compute that. So that's their independent variable. And then the analyses they wanted to do included things that they couldn't do at that time in TriNetX, including ROC, AUC, goodness of fit tests, and things like that. So I was talking to Amol about this talk over the past couple of weeks, and he pointed me in the direction of some of the studies that have been done and published using TriNetX on physical medicine and rehab related topics. So I pulled five of them in here. Feel free to look in PubMed for other ones as well. I selected one of those to go through and do the demo on. But before I do that, any other questions at this point about the basic functionality of TriNetX? This is just an excuse really to have another sip of coffee. All right.
Brian, can you please comment on like the right center and like they are putting this global IRB where if even if you need to use the download data for VCU, I think that is going to cover like some of the projects.
Unfortunately, the Right Center and the IRB and the Office of Clinical Research backtracked on
Okay,
having kind of a blanket predetermined approval. So you do need to go in study by study
okay,
for each one for which you need to download data. You still need to go to that non-human subjects research determination step.
okay.
I'm sorry to say. Every institution handles this differently, but that's how we're handling it for the meantime.
Okay, thanks.
All right, so I don't know it's the best article in the world, but I picked because it was relatively straightforward to do at least the query steps. This article that came out a couple of years ago by Buckley and colleagues on exercise-based cardiac rehab, looking at the rate of major adverse cardiovascular events in people with stroke. So what I'd like to do in most of the remaining time is to look at the logic of what they did, look at the codes they used, and then in real time, and you can do this at the same time with me if you have your TriNetX account and you have it open, to build the queries that would create the cohorts for a study like this. So here you see the research question. I put this into Pico format so that we can more clearly understand what we're going to try to do when we get into the query builder. So you can see that some of the criteria are beginning to be indicated through this, as well as the outcome and outcome time window. In their methods section, of course, they spell out the details for this. So they have the identification of the stroke population, the age, kind of a time window for phenomena that they're going to use, and then their intervention codes as well. So what that looks like is that both cohorts that they're interested in, one that had cardiac rehab and one that did not, had stroke. And there's two ICD-10 families of codes, I63 and G45 for that. That stroke occurred when patients were at least 18 years old, and it occurred at least 2 years ago to have enough of a time frame for the outcome measure. One cohort had cardiac rehab within 6 months, and that includes these um, different kinds of codes, ICD-10, HCPCS, and CPT. We're not going to go into the other steps today of what variables were included in the propensity score matching and what was included in the outcomes and how to set that up in TriNetX. We're just going to do these first couple of steps of creating the cohorts. Um, and now we'll see how well this doesn't work. If I go over, I'm going to have to relog back in here. We'll see if it makes me do the dual authentication as well. All right, good. So the first time you go into TriNetX, you will see the existing templates that are provided by TriNetX for everyone. If you're not doing an oncology related study, you can ignore those. If you're someone like me who uses TriNetX a lot, you may have a lot of studies over here that have been saved from prior work. And what we're going to do is we're going to go in and create a new study. So we have to do three things. We have to give it a name. We have to click at least one purpose. And we have to select at least one therapeutic area. Mm, they don't even include PM&R as a distinct thing. That stinks. Well, it's a neurological event, so we'll pick neurology. All right, you all should complain about that. That might happen more often than you'd like. So here's our main interface. We have that menu on the left. We have our query builder in the middle. And this is where we'll see saved queries on the right. I'm going to hide that for right now so we have more real estate to work on. So we're really starting from scratch. I don't want to use the Asian Pacific Collaborative Network. I'm going to pick the research network. And I'm going to start searching for terms. So there's a couple of ways you can do this. By the way, just as a reminder, your options here include demographics, diagnoses, some oncology terms, procedures, which includes E&M codes and things that are similar to visits, medications, labs, findings, and vitals, and genomics data points. So we're looking for stroke. And if I start typing, what will happen is it does sort of just a Google style thing of starting to bring up things in no particular order. It is just bringing up diagnoses here, but if it had procedures and medications mixed in, I could say, well, I really only want to look at diagnoses to find stroke, and then it would limit that to diagnoses. Now, if I'm not sure what codes are cover the phenomenon that I'm looking for, I can click the hierarchy tree doohickey over here on the right. And now I see codes in the hierarchical order. So now I can look above and below the thing that is closest to what I was looking for and see if I want any of those as well. And I can click the caret over here on the left, not CARROT, but the other one. And this will give me the kind of the child codes under the parent code. And if I pick the parent code, it's going to automatically be picking everything underneath it. So I don't need to say 163, I63 and I63.1, et cetera. I can just pick I63 and I add that to the query. and it shows up here as an ungrouped term. And there's some things I can do with it here, but there's other functionality that is only invoked when I pull that into a group of terms or a group of criteria. Grouping here is not groups of patients. This is groups of terms or criteria or conditions. The other code they had was, I think, TIA. So I could start typing in transient and I could go through that same process, but I remember that it was G45. So that's another way I can look something up and I can add that to the query. I switch the Boolean to or instead of and this is going to be the union of people with either of those two codes. I want to invoke that other functionality that I mentioned about setting in some time constraints, and I want to set age filters. Age filters I can set up here in ungrouped terms, but almost always I will bring all my searches down into groups. I might have one group for medication criterion and another group for diagnostic criterion. Not doing very good dragging right now. Here we go. So now whoops. So now I have in a group those two terms. They've left the ungrouped terms area, and now they're only down here. To set that 18 or older age filter the way that Buckley did, we're going to have greater than or equal to 18 and click Save in the upper right-hand corner. And I need to do that for each of these events. And then the other criteria, the other filter that they did was it had to have been more than 2 years ago. So if I want to set a time constraint on everything in this group, and by the way, I can give this a name because I'm going to have a number of different groups. We'll just do the word stroke. Group rules include specifying a number of instances or unique instances, adding a related group, which we're going to do in a minute, or adding time constraint. So I want to make sure that these events occurred at least 2 years ago. So I could either do that with a relative time and say, 3 years ago here, or however I want to do that. Or I could do specific dates and I could say from 01, 01, I could pick whatever date I want to do as my starting point and not use today's date, but do something like 12/31/28, 2021. And that now appears here. So hopefully you all can see that smaller writing that the filters for age at the time of event are indicated within each of these terms. And for this whole group of terms, the events occurred between 2010 and 2021. Okay. Now if I go back over to my criteria that I have over here, I've now completed this first step, and all the patients in my two cohorts have that much in common. The next thing would be creating one cohort that had cardiac rehab and one that did not. And it had to have been within 6 months of the stroke. Okay. So I'm going to do a couple of things. I'm going to find the terms for cardiac rehab, and then I'm going to put them create a related group. And that means I'm going to have a 2A and a 2B groups where I say that the intervention, occurred within 6 months of the event, which was the stroke. And in fact, what I can do is to begin that process. So I can copy group 1, because that's going to be my reference group. I can paste that logic down here in group 2. I can create a related group. And this is going to be temporally related. So this is where I'm going to say had cardiac rehab, and then in between these two sets of conditions 2A and 2B. I'm going to set the chronological or temporal relationship. But to find cardiac rehab, I have to come back up here. I know from the article that I'm looking for a number of different things. Um, but and usually you're not going to be replicating something. So if I type in the beginning letters of cardiac rehabilitation, again, it brings up a number of hits that it has. These so far are just procedures, but I recall that the Buckley group also had a diagnosis code. So I pop over just into diagnoses and I see if I can find something that looks like cardiac rehab. It would go through that same kind of process of finding something that looks similar and then hitting the code hierarchy tree. For the procedures, um, I know that they included a couple of these different ones, right? I think they had um, this set as well as some specific ones. I will say that in the article, they weren't really clear that CPT codes that you would see on a bill are usually 5 digits long, but there's also families, if you will, or concepts of CPT codes that have multiple ones underneath of it. So if I look at one of these 7-digit family ones, I can see, what's underneath of that and what's included. 10137171 was one of the ones, so I can include that. And it includes those two 5-digit ones, 93797 and 798, that they had said in the article as well, right? So I don't really need to specify them manually. Those are included when I click on the 7-digit concept code. So I can add that to the query. So it's just referencing the concept code. The other things were some HCPCS codes. And again, I can either type in the code itself if I already know that, or I can type in the words again, cardiac rehabilitation, and see if those come up. Just to save time, I'm going to type in one of these codes, which I already forgot, 451. I could do the hierarchy tree again and see what's around that in case I want to pick more than one. And just to show you a mix, I do want to type in the ICD-10 code as well. Exercise counseling. Z codes are kind of funny, kind of a grab bag of things in ICD-10 diagnosis codes. It sounds like a verb, but it's coded as a Z code under diagnoses. So when you have subject matter expertise, how would these phenomena be coded? Where would I look for these things? You might have to look at other articles if you don't already have that knowledge. That use codes. They don't even have to be TriNetX articles. They could be other health services research articles. So now I have some ungrouped terms here. I have my cardiac rehab terms ungrouped. And there's two ways I can bring them down into 2B. I can either drag them or I can click add terms and I can add that to must have and I can save. Again, these might not be all the ones that Buckley used, but it's good enough for our demo right now. And I'm going to give this a name. I'm going to say that's my rehab set of terms. Again, these are not yet groups of people. These are groups of criteria or terms. And I want to set a temporal relationship between stroke and rehab. And they had said within 6 months. Okay, so when I click on that, it brings up this window, this functionality where I can say any most recent or first instance of either the 2A event or the 2B event. 2A is stroke, 2B is rehab. So you can drag these across or you can use the buttons down here. and I'm going to say same day to 6 months. And then I look to see how it translated this to see if I did this the right way or if I meant to do it the other direction. Sometimes I get confused. So I look at the English translation up here. The first instance of rehab occurred within 6 months on or after the first instance of stroke. Okay, I think that's what I was looking for. So I click save, and now I have a group one of criteria, not of humans per se, but group one of my set of criteria where I have stroke in patients who were 18 or older at the time, and this occurred in this 2010 to 2021 period. And for those who, you know, in relation to the stroke event, I now am saying, and they had cardiac rehab within 6 months. Okay. And again, could have additional rehab codes down here. So that's my basic functionality that I've been aiming for. And if I count patients, I get 3,658 patients from 44 health systems out of 93. And I'm going to give this a name because I'm going to create, so that's this cohort or this query here that's saved. I'm going to minimize that history again over there. And I want to create my other cohort. So my other cohort is patients who did not have these things during their in 6 months within 6 months of their stroke. This is already saved. So now any edits I make on this, when I click count patients, it's going to save this as an unnamed cohort, an unnamed query. So I'm going to make use of that and say, I want a cohort that where for 2B, let me minimize group one here. Where for group 2B, they cannot have had rehab. Same temporal relationship. Now, the way it's written this in English, it's translated this into English, it sounds like it's still under the must have side. It's not really changing the language for the cannot have. So I'm going to give this a different name just so I don't get confused. And I'm going to say 2B is now no rehab. And now when I look at the English translation, it is the first instance of not having rehab, of no rehab, occurred within 6 months on or after the first instance of stroke. So that's what I want. It's a little bit awkward sounding, but I promise you that's what I want. And I can see the details for group one or minimize them. I can see the details for group two. Again, these are sets of criteria. Now, when I count patients again, it's not going to delete my stroke plus rehab query or cohort. It's going to save them and give me a new unnamed cohort that's going to be much, much larger than 3,600 patients. So this is a mutually exclusive cohort of patients that did not receive rehab. I'm going to delete this unnamed one here. I'm going to delete this unnamed one down here. So I have one cohort of 1.4 million people that had a stroke and no cardiac rehab, or at least according to the EMR data from those health systems, had no cardiac rehab, and a group of stroke plus rehab. Okay, now I can do all kinds of things with either one of these. I can go into explore cohort and look to see what their characteristics look like. Did I unfortunately pick the larger one? Pretty amazingly fast, right? 1.4 million patients data it's churning through. And once that finishes, I can look at demographics, I can look at diagnoses, I can look at their medications, I can look at their procedures. all kinds of things. If I was doing a clinical trial, I could look at their arrival rate or thinking about a clinical trial. So here's my sex distribution by age, some summary of demographics. Here's my summary of diagnoses, things that people have, look at their procedures, their medications if I want. Here's where I could look at rate of arrival and things like that. If I wanted to bring both cohorts over into a compare to outcomes, I would invoke the analytics, pick which thing I wanted to do. I could look at outcomes just for one cohort if I wanted, or I could do the compare outcomes with my two. And I can go back to my query builder and change these. Again, changes that I make are not going to delete or throw out the existing queries. When I click count patients, it's going to give me an unnamed version of the query in the cohort. And then I can give that a name too. I could say, well, I only want to look at men, or I only want to look at people who were 50 years old, not just 18-year-old, or things like that. So that is the demo of the basic functionality of the query builder replicating an existing study. And these are the slides just in case we needed them. But I wanted to have a few minutes for questions and discussion. And as Amal said, if you have a chance to use TriNetX in the next week, great. But even if you don't have that kind of time, if you have just 20 minutes to look up some other articles in PubMed or Google Scholar, um, TriNetX studies that were on phenomena related to your interest in PM&R, um, let me know. Is there a different study you'd like to use when we get to the analytics next week? Again, that cardiac rehab study has some weaknesses, and some of those other studies might be better for exploring um, outcomes. So email me those, but for right now, we can, where's people's heads? We can take questions. Yes.
I was just wondering if the recording of this could be sent out. That was incredibly helpful, but um, memorizing all the steps, I think being able to see it again would be very useful. Thank you.
Amal, do you know?
Yeah, I think we should be able to do that. So
I I will say that one way to really understand TriNetX is to use it. So if you do have a research question you're interested in working on, or you and your colleagues as a team have an interest, I am happy to work with you to go through these initial steps the first time, because getting over that learning hump for the first time of like, okay, how do I set up that relation chronologically between this criterion and that? Um, thank you. Um, is like you say, just looking at this passively, it doesn't sink in. Any other questions?
yeah, and I think as I mentioned in the beginning, we created accounts for all residents. So you should have received instruction on how to access it. And then Queen as I probably have also send that email out. But if you are missing those instructions, let me know. We can resend that. And again, anyone, I guess faculty doesn't need a sponsorship, but any other trainees, like if you have not received the account information or it has not been created, let me know and I'll submit that request again. So Yeah, but I think as Brian said, like for next week, if you have a chance just to like explore the platform, um, and then come up with some question, I think that would be really a good use of this because, I mean, we can go over like all these slides but I think, it's really, as Brian said, like if you go in there and just like start exploring, options and all that, I think that's really the best way to learn on how to use this. And again, like some of the articles that Brian showed, I mean, we just did like a quick search. I'm pretty sure there are many out there regarding like PMNAR and rehab using the platform. So if you find something you would like to send ahead of next week's workshop and would like to discuss that, again, we are happy to incorporate that in next week's presentation. So.
All right. Great. Thank you, guys.
You're welcome.
All right.
See you next week, but reach out between now and then with questions or ideas to explore. Thank you.
Wonderful. Thank you.